We have Dr. Ananya Chakarborty with us to deliver a talk on representation and interpretation of meta-analysis and summary of findings. She is professor and head of the pharmacology and also the coordinator of ADR Monitoring Center. She is currently working in Vydehi Institute of Medical Science and Research Center. She is also core committee member of the South Zone for ISCR. She has published more than 40 publications in various index journals and is in the reviewer committee team for the various reputed journals of international repute. Over to you, ma'am.
Thank you so much. Thank you for this opportunity. So the topic of my presentation is representation and interpretation of meta-analysis and the summary of findings. So in the beginning only, I want to tell you that, I am actually not a statistician, and I think most of us are not. So whatever we need for, our clinical practice, for our publication readings, I think we'll try to grab that much information today, and that should be the take home for all of us after this session. So what is prominent in the picture? They say that, shine bright like a diamond. So here also, if you see, this is a diamond, and that is sitting somewhere in this chart, right? Or we can say representation of some data. So this is a diamond, and I will, as we go through the slides, we'll learn what is the importance of this diamond here in relation to meta-analysis. So I will take the session with the following overview, introduction, and then we'll discuss about the main interpretation of meta-analysis, that is called forest plot, and then little bit about what are the various variables, the dichotomous and the continuous variables, and how we calculate the effect size based on these variables. And then what is fixed effect and random effect model in meta-analysis. And then finally, heterogeneity, and we'll touch upon publication bias. So a little bit about the introduction. So meta-analysis means mathematically combining and summarizing the results from, various studies that are already published in the topic or of our interest. So there can be several similar source studies, and usually the outcome that we look at should be the specific outcome of those studies. So a good meta-analysis is PRISMA compliant. I think we had sessions over months now as part of PGI Chandigarh and the ECO program. And I think I personally attended few of the sessions, and we had amazing sessions on what is PRISMA and then what is Prospero. So meta-analysis is PRISMA compliant, and it should be registered with Prospero. When we talk in terms of hierarchy of evidence, we all know that meta-analysis sits at the top of the pyramid. So we have case reports, case series, case control studies, cohort studies, then RCTs. RCTs can be cohort studies, or they can be cross-sectional studies. And then we have systematic review, and finally it is meta-analysis. So, before I go to the core topic, let us discuss a study. So this study was published in the year 2020, and it was published at BMC Health, Oral Health, and this is a study from our dental colleagues. So the study was conducted to evaluate, it is a systematic review and meta-analysis where they tried to evaluate the whether oral lichen planus is a risk factor for peri-implant diseases, that is PIDs, right? So oral lichen planus, whether it is a risk factor for peri-implant diseases. So they looked at all the published articles from five sites like Medline, and then Embase, Web of Science, the Cochrane Library, and Scopus, right? So they took an account of all the previous studies that were published on oral lichen planus and in peri-implant diseases, right? So what did they do? They They also scored the studies based on the scales, the Newcastle Ottawa scale, or the Agency for Healthcare Research Quality, and the quality of the articles regarding the risk of bias and methodology, they were evaluated using these two scales. And then the primary outcome, it was implants having PID, that is and then the secondary outcome was probing depth and then bleeding, etc. So heterogeneity was assessed by I-square test. Dichotomous data were expressed as risk ratio and 95% confidence interval, which were calculated with a fixed model effect model. Right. So this is the methodology. Now coming to the results, out of the 66 articles, 2 studies were enrolled and evaluated as high quality. So out of 66, only 2 studies, and which totally contained 68 participants receiving the treatment, right, and the control group. So the meta-analysis revealed no recognizable difference in the number of implants. So we'll discuss the forest plot for this study. So but let's read the conclusion first. So available articles regarding the effect of OLP on PIDs remain very, very limited. Existing evidence does not support OLP as a suspected risk factor. So let us try to read the forest plot for this study. Yeah, so what do we see here? So here there are listing of the studies. So how do we list the studies in case of meta-analysis? It is the, the last name followed by the year of publication, right? So it is 2011 and 2012. So this is the most common way of listing the studies. Also, they can be listed based on chronology, and rarely they are based on the effect size. So now we see various columns here, like column 1, 2, 3, 4, 5, 6, almost 6 columns. Now, what are these columns, right? So here OLP, that is oral lichen planus group. What happens? How many events? Right, what are the events? What do we mean by events here? Event is, this is 1 and this is 2. So 1 is peri-implant mucositis. So what the authors were trying to see, whether lichen planus, oral lichen planus is a risk factor for peri-implant mucositis. So to come to the conclusion that it is a risk factor, so what they have to do is they have to have a control group, and there also they have to follow up patients with peri-implant mucositis. So here we have 2 groups. So one group, and this is the control group. So what type of study is this? Because they followed up the participants. So this is a prospective cohort. So it's a prospective cohort study where they followed up the patients, right? And now what we see here is, this is the total number of participants. Here total is 56 for the OLP group, and it is 60 for total is 60, but here events, yes, it is for 60, total 60. Event is 4 here event is 5 out of 56, and it is here out of 60, right? So now like there is this here you see the summary of the study. So what is the summary? So total participants in the OLP group were 112, whereas total participants in the control group were 110, right? So now here we see something called weight. Now what is the significance of this weight? Right, what is this weight? Right, so you have 2 studies where you have 2 risk ratios. So for study number 1, here if you see, the risk ratio is 1.34. That is the effect. This is the effect size. So based on the effect size, we can come to a conclusion about how much weight the study, that is study number 1, contributes, how much the study 1 contributes to the meta-analysis. So weight, I will in my the slides, I will talk about how we derive weight. So here weight is 31.4%. In the second study, the weight is 68.6%, right? And then here you see 0.38 and 4.74. Now what are these? So if the confidence interval is 95%, then we assume that if we extract this, or if we extrapolate this value, this risk ratio to a bigger population, right? So then if we continue if we repeat the studies 100 times, then 95 times there is chance that, the risk ratio will fall between, this is the point estimate, and here, left and right. So this will be minus, that is 1.34 minus 0.38. On the right side, it will be 1.34. This is 1.34. This is 1.34. That is risk ratio plus 4.74, right? So same for the second study, this is the point estimate, and the left side it is 0.72, 1.56 minus this one. On the other hand, it is 1.56 plus 3.41. So that means if we extrapolate this study to a bigger population, right? So there is chance that our our confidence interval will 95% confidence interval. If we take the confidence interval to be 95%, the mean will fall between these points. 1.34, you see, this is 1. So 1.34 is somewhere here. 1.56 is somewhere here. And this is called the point estimate for the study. That is our effect. That is the point estimate. Now, based on this, we derive the total outcome. Now, what is the total outcome here? 112 patients in the OLP group, and in the control group 110. The weight, overall weight is 100%. And what is the overall risk ratio? It is 1.49, and confidence interval is this one, right? So this is the diamond that shows, like, the center of the diamond will signify 1.49, and then this will be minus 0.77, and this side it will be plus 2.90. And what does this line denote? This is the line of no effect. So that means here it means same risk. That is the this side it favors OLP, oral lichen planus. On the other hand, like if the value is more than 1, it favors control, and if it lies in 1, it means that both the group have the same risk to develop oral lichen planus. Right? So from here, like, let us go to the test for overall effect. What we see here is there is a Z. So for the overall effect, that we calculate with the help of Z test. And what is the Z value here? It is 1.18, and P value is 0.24. And P value 0.24 by 1.24 means the results are not statistically significant. So if the results are not statistically significant, and then that means these two studies are homogeneous. Also, that can be seen from the chi-square heterogeneity test. Here the chi-square value is 0.84. That is no significant difference. That is, there is no heterogeneity in the studies. And the I-square value, by I-square gives the probability of of heterogeneity, and that is 0%. That is, the studies are not heterogeneous, the studies are homogeneous. And by taking a look at the forest plot also, just by seeing, we can say that the studies are homogeneous, because both are both falls on the right side of of this line, that is the line of no effect. And if you see here, like, both the confidence intervals that touch the line of no effect, even the diamond is touching the line of no effect, and that means that the results of this study are not significant. That means oral lichen planus, we can conclude that oral lichen planus is not a risk factor for peri-implant mucositis. Right? So same for the other table, like here also, if you see, This is for peri-implant disease. So like the first study, like here also they're divided into two groups, the control group and the oral lichen planus group, and they weighted the study. Then this is the risk ratio. And what is MH? So this is, they have conducted the study in a fixed effect model. I will tell you what is a fixed effect model. And they have used this method, Mental-Hensel method. So this is a meta-analysis method and fixed model. So here also, if you see, the diamond falls in the line of no effect. So that means there is no significant difference between the lichen planus group and the control group towards the risk for developing peri-implant diseases. So we can conclude that oral lichen planus is not a risk factor for oral lichen for peri-implant diseases. I hope this is clear till now. Let's discuss another study. So I have taken these two types of studies because if you see here, this here it was written fixed effect model, and if you come here, there is little difference. Here it is random effect model. Now let us try to see what is published in this study. So again, like if you see to the extreme left, this column is for study or subgroup. That is, and that what is the weight change endpoint. Okay, so here you see like there are two groups, topiramate group and placebo group. So what they want to see is whether giving topiramate there is any change in weight compared to the placebo group, whether topiramate causes weight loss compared to the placebo group. So for that, these are the studies listed. So again, like I told you before, like the name of the author, the last name of the author followed by year, and then here the studies are not listed based on chronology, right? So they are different years, but yeah, so these are the different years, but they are listed based on the last name of the author and then the year. So yeah, ARK and then MNT. So yeah, this is, yeah, based on the alphabetical order, they have, listed the studies. Now data on mean, standard deviation and weight. Now, so what is this? 63.2 is the mean value. So when they gave topiramate, what was the mean weight in the group, treatment group? It was 63.2. What was the standard deviation? It was 20.4. How many participants were there in the study? And that was 16. So that study was conducted on 16 participants for the treatment group. And let's see for the placebo arm, how many? Again, there were 16 participants. So mean in the topiramate group was 63.2. Mean in the placebo group was 68.8. So what is the difference in mean? So you can see this value here. So this is the mean difference. So there is something like that I want to comment here, like this should be mean difference, but not the weighted mean difference. So this is the mean difference. So the mean difference is 5.69. So likely, like in all the other studies also, see mean is minus 1.49, and then here it is 2.72. And then this is the weighted mean, right? And then what? Like, so this is the mean, this is the standard deviation, this is the number of participants. Now, if you look at the subtotal, overall effect, you see that in topiramate group, 176 participants were enrolled, whereas in the placebo group, there were 151 participants. So now if you ask me, why should we do meta-analysis? So this should, this point should, give us an idea, because if you see in these studies, there were 16, there were 32 participants, 17 participants, and, we may not get a conclusion based on the sample size, because sample size 16 like seems to be very small. But if you take the pooled data of all the participants from this many studies, then you are conducting the study on 176 topiramate versus 151 placebo. That is, your sample size, overall sample size is more. So we can expect that our study will be more precise, right? So now let's see here. Yeah, so one thing that caught my eyes here is, like, if you see this author, Co et al. 2005, they have given 100 milligram and they have given us the mean and standard deviation. Whereas again, the same authors have given 200 milligram dose and again they have, listed the mean, right? Mean and then the placebo. So so I kept thinking whether it is the same study where they have given 100 milligram dose to one group of participants, 200 milligrams to the other group, and where the placebo group, received the placebo. So whether here, if you see, they have mentioned that there were 10 participants in the placebo group, here also 10. So whether it is 10 or whether like this is the overall number of participants in the placebo group. So there is little confusion in this study, right? So however, so total participants 176 and this side it is 151. So weights are actually assigned by inverse variance model. Weights are assigned by inverse variance method, and once you have the weight, it is extrapolated to 100%, right? So out of 100, what should be the weight for the study? Now if you see, out of all these studies, which study has the more weight? 16, 17, I think it is this study, right? It is the Kim et al. Study. So it's given that the weight is 17.1, 17%. That is, this study has more weight. Now this more weight should be based on, as weight is inverse of variance, right? So we assume that if number of participants are more, then weight will be more. So summary of data, like, so these are the summary of data in the forest plot. So let me discuss the summary of the first study. So we see there's a line here, and like in the previous studies, we saw that they had, like, the effect size was risk ratio. So what is the effect size in this study? So the effect size is actually weighted mean difference. Mean difference, what is the difference? Mean and then weighted mean difference. This is the effect size here. All right, so if you take the summary of the first study, you can see a small green dot here. So what does this dot signify? This is nothing but this is the mean. This is 5.69. Let's see, like, minus 5.69. Yeah, let's try to see if this is minus 5.69. This is minus 5. This is minus 5 on the x-axis, and on the y-axis, if you see, this is 5.69. So this is the point estimate. So in case of meta-analysis, we call it point estimate, right? So we have lines towards the left and right of point estimate. So this point estimate is supposed to be based on the weight of the study. So if weight is more, point estimate will be more. So if you see, this is very small, it's a small dot, but compared to this estimate looks big. And if you see here, the weight of the second study is 12%, whereas the weight of the first study is only 2.4%. So that means this study has less weight. So point estimate is small. Okay, so point estimate is small here. So right and left side, we have the confidence interval. So towards our right, okay, so towards our right, it favors control. Towards our left, it favors experimental group. So this side favors control and this side favors the experimental group. So what do we see here? We see an arrow here. So what does this arrow signify? Okay, we know that. And if you see the summary estimate, so this study has a wide confidence interval, right? It from minus 10 to almost reaching 8.73. But why there is an arrow here? Because if you see here, it's 5.69 minus 20.1. But here the limit is up to 10. So that means if given a chance, or actually this line should extend more. So since here it is depicted till 10, so here they have placed an arrow. Okay, so I hope this is clear. Also, from this summary, can we talk about the significance? If you see this line, it crosses the line of no effect. Now, once a study crosses the line of no effect, we can conclude that the results are not going to be significant. Whereas this one, if you take example of this study, the diamond is big, and then the right line is not crossing, or it's not touching the line of no effect. So this study favors experimental group, right? So this study favors topiramate. So what does it mean? That means when you give topiramate and your outcome is weight, right? And weight is what type of variable? Is it a continuous variable, or is it a dichotomous variable? Weight is a continuous, right? So here this study favors weight, means when you give topiramate, the patients in the topiramate group, there was reduction in the weight. So how many of such studies are there? How many studies are there overall in this plot? We have 1 2 3 4 5 6 7 8 studies, right? Out of 8 studies, this one 2 3 4 studies are crossing the line of no effect, whereas 1 2 3 4 these studies do not touch the line of no effect, and the confidence interval, the point estimate and the confidence interval in these studies, they lie to the right side of the this line, towards our left or right side of this line. So what does this mean? This means that the studies are statistically significant. So now, like, just imagine, like, if you had read these 4 studies, just segregated, okay, 4 studies say that, topiramate does not have effect on weight, whereas 4 other studies, they mentioned that topiramate has reduces weight. So now, how do we come to a conclusion whether topiramate actually reduces weight or it does not reduce weight compared to the control group? So if you pull the data from all the previous published studies, so what happens? You get a conclusion like this. Your sample size increases 176, and your mean weighted difference is 3.14, and this is the confidence interval. So on the center of the diamond will be your 3.14 value, and then this side will be minus up to 3.14 minus 5.55, and on the right side it will be plus minus 0.73, right? So this is the diamond. So now, looking at the diamond, we can conclude that there is the effect is significant. Now let us see here. What does it say from the test of overall effect? The Z value is 2.55, P is 0.01. So 0.01, P less than equal to 0.05 if you consider as statistically significant. So from the Z value also, it tells that the study favors the topiramate group. Now let us try to find out about heterogeneity. The chi-square value is less than 0.0001, that is highly significant. So what does this mean? Heterogeneity is highly significant. Now what does it mean? That is, the studies are heterogeneous. Now what heterogeneous? What is the probability of heterogeneity? Here it says 86%. So anything more than 75% is considered as highly heterogeneous. Okay, so highly heterogeneous. So this is a highly heterogeneous study. And since this is a highly heterogeneous study, so the results are expressed as random effect model. And what is IV? It is inverse variance. Inverse variance is required for the calculation of weight in the study. And now, like, if we look at the listings, now which study has the highest weight? Which study has the highest weight? Which study has the highest weight here? One is this one, the other one is this one, right? But a highest weight, this one is the third study, but it crosses the null effect. So let us exclude the study. If we exclude this study out of the studies that are significant, which has the highest weight, and it seems like this study 16.5, that is, this study has the highest weight. Now if you see the look at the confidence interval, right, it has a narrow confidence interval. So this also gives an idea about the weight of the study. Narrow interval means the weight will be more. Okay, so this is about the study number 2, the forest plot. Then this is another study. So here also, like why I posted this study is because here the outcome is through standardized mean difference. So this is the difference here, standardized mean difference. And the other point that we should remember is, in case of risk ratio, if you look here, it is at 1. Now, why is this 1 and why is this 0? In all the 3 studies, the null hypothesis line, it is at 0. Whereas in case of risk ratio, the line is at 1. Now, why is it at 1? Because you have 2 options, right, here. Either oral lichen planus patients, their risk can be more or risk can be less. So there are 2 options. So you divide. Since it is a ratio, it cannot be 0. Since it is a ratio, it is at 1. Now, what are the various measures of outcome? Like, like in the forest plot, we have seen the outcomes like risk ratio, then odds ratios, standardized mean. So for dichotomous outcome, it's like the two, like the fork, right? So it's like risk ratio, odds ratio, risk difference. Continuous outcome, for example, weight. When we talk about weight of the person, right? So that is usually is the outcome is measured by standardized mean difference, response ratio, or raw mean difference. We have seen in the previous studies. There I have given example of 3 studies. So in the 2 studies where the outcome was dichotomous, the outcome was measured by risk ratio and odds ratio, whereas in the other case where the outcome was continuous, so that is weight of the person, like topiramate group, whether it gained weight or lost, reduced weight, right? So there it is through standardized mean difference. So now I think we, after the intro, like what are the 6 columns of the meta-analysis interpretation? So we have the first column is the total number in group, and that is one is total number in the group, and the other small n is the number in group with the outcome, right? This is a total number 131, and n is out of 131, how many in the intervention group? That is 1. A control group 133, how many in the control group? It's 2. That is, we are talking about some outcome here. So then we have the study IDs listed, and here again it is listed based on, if you see here, it is not based on the names of the authors, but it is based on chronological order, 2000, 2003, 2005 studies, right? Intervention group, then control group, then relative risk, and then this is the diamond, line of no effect, right and left, and then 95% confidence interval, and then we here, where is the overall effect? Total, yeah, this is the overall effect of the study. This full row is the overall effect of the study. So intervention group, there were 512 participants. In the control group, 542 participants, and the relative risk, that is 0.87. So again, if you see the diamond, it touches the line here, that is the line of no effect. So the results are not supposed to be significant. So what is the I-square value? It is 0. That is, the study is not heterogeneous. The study is not heterogeneous, and maybe you need the fixed effect model for this type of study. So now, based on the previous, based on this diagram, like which study looks interesting? What are the questions that should come to our mind when we are studying this forest plot? So which study looks interesting? what represents the effect size, what is 95% confidence interval, what is fixed model meta-analysis, what is line of no effect, what is the influence of an individual study on the pooled results, that is the weight of the study. So which study looks interesting here? Which study looks interesting? Which study looks interesting? I think, yeah, this study, you know, like the square is big. Here the square is big, but again, like it falls on the line of no effect. Yes, even the diamond falls on the line of no effect. What represents the effect estimate? It is the relative risk. The effect estimate is through relative risk. What is 95% confidence interval? So we know that if we extrapolate this data to a larger population, so the 95% confidence interval will be between 0.50 plus minus 0.05. On the other hand, it will be plus 5.49. So representation of a study, like a very important, we should remember, like this is the effect estimate, or this is called the point estimate, center of which lies the mean, and then this is there is a line of no effect, and then this is the confidence interval. So that has two lines to the left and right, after, like, on both sides, you can say two ends of the point estimate is the confidence interval. Right hand and left hand of point estimate or effect estimate, these are the this is the confidence interval. So now, like, can the study be extrapolated to entire population? Can you? Okay, I see, like, there are not too many participants. Okay, so yeah, so question to you all: can the study be extrapolated to entire population? Can you type your answer in the chat box? Yes or no? Yes or no, please. Can the study, whatever studies we discussed, can these studies be extrapolated to entire population? Can we represent through the meta-analysis? I see no response. No, yes. Okay, yes. Yeah, yes, the mean will be close to the line of no effect. Okay, so I think we understood that the studies can be extrapolated, and that's why we are representing the study in terms of mean and the confidence interval. So now, if the study is extrapolated, what will be the mean value? Okay, so the mean may not lie very close to the line of no effect. It will vary based on based on the study, right? It can fall anywhere so we'll discuss that. And now, so what is confidence interval? So how do we okay, so how do we measure confidence interval? So in simple words, what is confidence interval? It is the range around sample mean. It is the range around sample mean. As I told, the right and left hands of the point estimate, right? So confidence interval in simple words means, we can get an idea of the confidence interval, whether it is wide or whether it is narrow, by this equation: mean plus minus 2 standard error of mean. Why I mentioned 2 standard error of mean? Because we are talking about 95% confidence interval, that is 2 standard deviation, right? And SEM is by standard deviation divided by root over n. Right? So now my question to you is, if n is more, number of participants is more, what will be the SEM? Will it be more or less? So if n is more, since it is in the denominator, so SEM will be less. Yeah, thank you, Shabir. Yeah. Now when SEM is less, confidence interval will be less, right? Because confidence interval takes into account mean and standard error of mean. So when SEM is less, confidence interval will be less. So will it be same equation for both outcome measures? By both outcome measures, I mean for the dichotomous variable and on the other hand for continuous variable. What do you think? Is it same for both outcomes? Can we just look at the formula and say, yeah, confidence interval will be more if number of participants is less? So what do you think? Yeah, what percent false? Yeah. So what do you think? Will it be same for both outcome measures? So for dichotomous variable, we have a different formula. Okay, so we have a different formula. I think, we should not bother much about the statistical part because there are softwares that will take care of this. Once we have the values, if you have the odds ratio, then the software will calculate and give you the weight, and you can measure the variance of the study, and then, automatically, even if you Google, you can find out the confidence interval for the means. Right? If you just say, okay, my mean is this one, so what will be the confidence interval, and you get the answer. But on the other hand, we should just try to understand the basic concepts. So, here it is not only dependent for dichotomous variable, it is not only dependent on n, it is also dependent on the risk, right? Outcome and the risk. So which study looks more precise, study 1 or study 2? Which is more precise? Say this is BP value. So mean is 120, confidence interval for the first one, it is 110 to 130. And for the second, it is mean is 120, mean remains the same, confidence interval is 90 to 150. Study 1, thank you, Shabir. Here, like you see, like confidence interval is small, right? Confidence interval is 110 to 130. So this study is more precise. So as I asked before also, like whether like we can extrapolate a study, right? We have study number 1, study number 2, and now can we extrapolate the study to the to a bigger population? So when we extrapolate the study 95% confidence interval, we mean that the confidence interval lies between 2 standard deviation. That is, this is the part. So this is the part where all our study means will lie. So how do we calculate the weight? So this is a simple formula. So weight is expressed in percentage. It reveals the contribution of each study towards the overall summary results. For example, see, if a study has been conducted with 10 participants. On the other hand, a study is conducted with 100 participants. So what do we feel based on our assumption? Which study will be more precise? Which study we usually say, right, this study is good, the sample size is so big. So this is the same thing. So weight is dependent on the sample size, right? So weight is calculated as inverse of variance, right? So that is 1 by in the denominator you have the standard error of mean, and we know how to calculate standard error of mean. It's standard deviation divided by square root of the number of participants. So if n is more, weight will be more. So now in this study, which study has more weight? 1, 2, 3, 4, 5, 6. There are 6 studies, and again you see like they are arranged chronologically, right? So which study has more weight? Number 4, Prashant, study 4. Okay, group 1, group 2. Yeah, this is study 4. What is the weight of study 4? Like you see, you can look at the forest plot and you can come to the conclusion that study 4 has, more weight. Now it is 31%. It contributes 31.7%, right? So now if it contributes that much, now what is the sample size? In group 1 and group 2, in study 4, the sample size was 34 plus 20, that is 54, right? So I think the sample size, if you of both the group 1 and group 2, so this study has more sample size and weight is also more. So if you do not have these values also, by looking at the forest plot, we can conclude that, study 4 has more weight, right? Yep. So significance of the line, what is the significance of the line? Line of no effect. Line of no effect is the line where outcome variable value is neutral, right? Basically what it means is, suppose you have given a drug and you want to compare the effect in the study group and the placebo group. So if The studies fall in this line, that is line of no effect. It means that it is neutral. There is no clear difference between intervention and the control group. So many studies are listed here, but only few studies are not touching the line. That means these studies favor the experimental group. So interpretation of odds ratio, I think we all already know. So 1 or close to 1, odds of exposure is same. Greater than 1, odds of exposure is greater than control. Less than 1 means odds of exposure is lower than control. Then what is the interpretation? Okay, let's take an example. There is an outbreak of a disease. And in a case control study, case control means retrospective. Case control study, investigators found that 21 of 30 patients and 4 of 60 controls, and 4 of 60 controls had eaten raspberries. So inserting these numbers into 2 by 2 contingency table, so we arrive at the odds ratio, that is 32.7. So here, we want to see whether eating raspberry was a risk for cyclosporiasis, and the odds ratio came to 32.7. So what to conclude from this? Raspberry, is it a risk factor for cyclosporiasis, or is it not a risk factor for cyclosporiasis? Yes or no? Okay. Raspberry is risk factor for cyclosporiasis. How many of you feel that it is yes? It's a risk factor, Gautam. Okay, thank you. So it's a risk factor. I think I will share my PPT. So I think you can go through it so that you have more time to think about these values and calculate and understand. Yes, Anamika, thank you. Yeah. Shudeshna, thank you. Yes. So same way we interpret for relative risk also, 1 or close to 1, risk is similar to both groups. Greater than 1, risk is greater in the exposed group. Less than 1, risk is less in the exposed group. So here there is another study. This study calculated the relative risk, almost same, but outbreak of cyclosporiasis is associated with a banquet. So people ate this dessert, the raspberry dessert in a banquet, and then they were hospitalized. They became ill. Only 1 of 11 attendees who did not eat the berry became ill. Inserting these numbers into 2 by 2 table, actually we can calculate the relative risk. Now, what is the risk? What are we trying to find out? Whether eating raspberry exposed to berry dessert were in high risk of developing the disease. So it was found out, the relative risk value was found out to be 10.2. So people exposed to berry dessert were 10 times more likely to develop the illness. So why I'm talking about this risk ratio, odds ratio, because these are the outcome measures in meta-analysis. So we have to master these values, these calculations, so that we can interpret them better. So again, interpretation of forest plot. Okay, let's see. Yeah. So this is a study. Okay, heterogeneity. That is 86%. That means highly heterogeneous, right? I think I had given the same example before. So my first question to you all is this a fixed model or a random model? Fixed or random? Please type F or R. Highly heterogeneous. I square is 86%. R. Prashant, thank you. So this is random model. And what about this value? This is weighted mean difference. It should be 1 or 0. It's 1 or 0 here. Line of no effect. The outcome is weighted mean difference. Outcome is 0 or 1. It's 0 or 1. 0. Very good. Thank you, Deepika. So reading the figure, like again, let's try to memorize whatever we discussed. So we need to understand what is weight percentage, what is weighted mean difference, that is outcomes of study, then what is inverse variance, then what is random effect model, what is effect size, what is point estimate, and what is confidence interval. Now, little bit I'll tell you about fixed effect model and random effect model. So we saw that model parameters are fixed here. The values of independent variables are assumed to be constant. In case of fixed, values of independent variables are assumed to be constant. Whereas in a random model, there may be other independent variables and which are adding to the values, because of which the parameters are not fixed. Weight is inversely proportional to study variance and effect size depends on sample size. Whereas in random effect model, there may be other parameters that may affect the study size. That means heterogeneity comes into the picture. Okay, so heterogeneity comes into the picture in case of random model because there may be other parameters. So when I talk about heterogeneity, you have to understand the term like subgroup analysis. Why the data is heterogeneous? Then you can go for subgroup analysis. Okay, you have given topiramate in patients. What were the age group? Right, whether patients who are above 30, whether they have more effect compared to patients whose age is below 30. So all those points will come into factor, whether they are on any other medication, whether they are on any other pain therapy. So all those comes into consideration in case of a random effect model. So the size depends on sampling error and underlying distribution. So which model we should use? In case of homogeneous studies, it implies that point estimates vary only due to random variation. Whereas it is here, it is due to real differences. Okay, if pain is more in an age group more than 30, whether there is a genomic component, whether there is a pharmacogenetic component. So all these come into the heterogeneous studies. That's why the study becomes heterogeneous. So that we have to, fit into the random model. Effect size already we have discussed. And then the types of measurement, we have dichotomous. For dichotomous variable, the effect size is in odds ratio or hazard ratio. Hazard ratio is nothing but cross-sectional of risk ratio. Continuous models, we have mean difference, standardized mean difference, and then for ordinal data, mean, mode, etc. can be used. So I had calculated the odds ratio. So I think we know this is the very common example given, lung cancer, and then smokers and non-smokers. So 25 odds ratio means there is a risk. Here 5 risk ratio, relative risk, like this risk ratio we use for prospective studies, odds ratio used for case control studies. Then standardized mean difference, we have used it for the topiramate study. It is used when study report efficacy in terms of continuous measurement, such as, so in our study, topiramate study, what was the measurement? It was body weight. So that is a continuous variable. So how do we measure SMD? That is new treatment improvement minus placebo improvement divided by pooled standard deviation. So what I mean to say is, there are statistical formulas available. So just feed in the formula and, you will get the forest plot. So what is heterogeneity? In meta-analysis, it refers to the variation in study outcome between studies. Okay, so we have seen studies that were homogeneous, studies that were heterogeneous. Now the classical measure of heterogeneity is Proken's Q. Now, which plot is more heterogeneous? So there is this, they say that, you can do the eyeball test. So my suggestion to you is just to look at the pictures and read what your eyeball reads. So based on your eyeball sign, which study is more heterogeneous? Study 2. Lavita, thank you. Study 2, yeah. So this study 2 is more heterogeneous. Now, why do we say it is more heterogeneous? Because you see the confidence intervals, they're lying, at various places across, right? But whereas here, the studies are almost, they're fitting into this parameter, right? So this is homogeneous, more or less homogeneous, but we don't know whether this is a homogeneous study or not. It can have mild heterogeneity. So what is mild, moderate, and high heterogeneity? Heterogeneity extent is evaluated by I-square test. Interpretation less than 25%. I-square value means low heterogeneity. That is, you go for the fixed effect model. 50 to 75% is moderate heterogeneity. 75 to 100% is high heterogeneity. So when there is high and moderate heterogeneity, like we can go for the random effect model, whereas here when low or no heterogeneity, when studies are homogeneous, if you just scroll through the studies, you yourself can get an idea about heterogeneity. So then in case of homogeneous studies, we go for the fixed effect model. In case of highly heterogeneous or moderate heterogeneous studies, you have to fit in the data to the random model. All right, now you see like the I-square value is 86%. So this study, like if you look at, so this study is highly heterogeneous. It may be because of this point, right? Maybe because of the first study. You see, like I had talked about the arrow, right? So the confidence interval doesn't stop here, it extends, right? Because up to 20, here it was -10 and then another 10. Right, so first study itself is the one which can like widen the confidence interval. Now what do you do? So if you delete study number 1, whether the study becomes homogeneous, if you delete study number 1, that is this one and this one, then whether your study can become homogeneous, right? Can you do that? Yes or no? If you delete one and this study, whether yeah, Gautam, Nisha, thank you. So maybe the study will become, the plot will become homogeneous, right? Maybe it's 86%, that is highly, yeah, sensitivity analysis. So here you can go for sensitivity analysis. So I have a slide on sensitivity analysis. I'll show you what is funnel plot. So here I-square 64, that is moderate heterogeneity. Now again here, this is a good study, yeah. So maybe because, so many studies, 1, 2, 3, 4 studies are touching this line, 1, 2, 3. If it was only these 3 studies, maybe it would have given the significant result. So heterogeneity, like homogeneous studies, fixed effect model, heterogeneous study, we have to cross check the data, skip the meta-analysis, explore heterogeneity first, perform random effect meta-analysis, transform measure of outcome, and perform sensitivity analysis. So these are the steps. And then subgroup analysis. What is subgroup analysis? A way of finding out if a treatment program of intervention was more effective for some people than others. As I was discussing about pain, above 30, below 30. So the type of conditions causing the pain, how long the condition has been present, whether, some people felt pain for 3 days, others felt pain for 7 days. So whether you took those into consideration, whether treatment works below a certain age. So all these factors can come into consideration in case of a random effect model. So now what is meta-regression? Meta-analysis that uses regression analysis to combine, compare, and synthesize research. It can be either a linear or logistic regression model. I'm not going into the details because as I told in the beginning itself, as medical doctors, as researchers, what we need to do is we need to, understand the basics of, reading a forest plot, basic steps of, enrolling a study, basic steps of going forward with a meta-analysis, write a protocol, and then, go through the guidelines, check in Prospero where you can do the study, right? So that is more important. So sensitivity analysis, as I was mentioning, whether you can omit some studies so that, the studies become more heterogeneous. And then bias can be publication bias, time lag bias, citation bias, language bias. So all these type of bias can have effect on the study. So bias reporting, like you had mentioned, like, how we can identify like whether studies based on the confidence interval, like if you see here, so which is a good study? Reporting bias. Okay, which study has bias, 1 or study 2? I think this is my last slide. So study 1 or study 2 has bias, chance of bias? Study 2, yeah. Yeah, Gautam, thank you. So study 2 has bias. So how do we know that study 2 has bias? Now, if you look at 1, right? So these are all confidence intervals, and you see like these are, this is there throughout the plot, right? But in case of here, this place is just vacant. The studies are scattered in this part of the plot. So what that means is this study has more chance of bias. So with this, I conclude my session on interpretation of meta-analysis data. So any questions? I think you can.
Thank you, ma'am. Thank you very much for such an informative lecture. I think you have elaborated in a very beautiful way with all the examples like oral lichen planus and other case control studies. Participants, if you want to ask any question, you can ask to ma'am directly, or you can post your questions in the chat box also.
Can I make a comment?
Yes, please.
Yes, ma'am.
I would like to thank Dr. Ananya for such a beautiful lecture on interpretation of meta-analysis. I think everybody has benefited from various examples which Dr. Ananya has quoted. And Dr. Ananya, it is really wonderful to have you included into our group. And we really hope that you will also take some future lectures. I mean, the way you make everybody understand is really wonderful.
Thank you so much, ma'am. Thank you. Okay, so I think there are questions on moderator analysis, mixed effect model. I think, madam, can I take these questions over email?
You can take up them just now. You can take them if you want to.
Yeah, I think I'll take it over. I think take later. I think I will respond to email. So you can share my email ID. It's small d Dr. Ananya.chakraborty@gmail.com.
Sure, ma'am. Sure. I'll ask you through mail. Thank you.
Any questions, participants? Okay, if anybody wants to ask, they can contact with ma'am with the email provided in the chat box.
Also, I will share the PPT. I think you can share with the participants.
Sure, ma'am. Okay, I think we should close the session now. Lastly, I would like to thank you, ma'am, on the behalf of Center for Advanced Research, Evidence-Based Child Health, NER, PGIM, MER, Chandigarh. We are very lucky to have you in our team, and the lecture you have given today is very, very informative and very beautifully done, especially for the upcoming researchers like us. We are just like in the budding stage, and we are just doing the meta-analysis, and there are many things we learned today from your lecture. Thanks a lot, ma'am.
Thank you so much for this opportunity. Thank you.
Thank you, ma'am. Have a nice evening.
Thank you.